Good morning. I'm Andrew Saxon. I'm going to be chairing the session this morning. I'm from University of Washington and the VA in Seattle. And our session this morning is from start to finish. The first three speakers will be talking about the START study, of which I was one of the lead investigators, and that was a very large multi-site randomized comparison of methadone and buprenorphine, primarily looking for their effects on the liver. And I can tell you very quickly that we didn't find that either medication had adverse effects on the liver, but what you'll be hearing this morning are some very important secondary analyses that came out of this large study. All of them, I think, extremely relevant to members of ATOD who do this work on a daily basis. So I think you'll find it illuminating and helpful as you return to your work. And the second segment, we're going to have some international presenters who are very much going to complement some of what you'll hear about the START study, and at the very end we'll tie it all up into some important themes, and we'll have plenty of time for everyone to have input. So there is, and we will take a 10-minute break after the first half. There is a yellow sheet for your evaluations, which we would very much appreciate you filling out. And of course, I'd like to thank National Institute on Drug Abuse for sponsoring the symposium, and SEI with Sean Randall and Katya Howlett for helping us to with the logistics and getting it all organized. So is there anything else I should say before okay, so primarily we do have some very prominent speakers. Primarily I'm going to let them introduce themselves. And so our first speaker is George Woody, who's from right here at the University of Pennsylvania, and he is going to be speaking on the HIV risk reduction with methadone and buprenorphine.
This is a PC and I have a Mac.
Okay, let's see. Okay, so we're going to have the blind leading the blind here.
Oh, there it is. It's simple.
And here's
then
okay, so
Okay.
this is pretty standard, so
Yeah, just
forward,
this is
back, and there's the red
Right,
laser
okay.
pointer, and I'll be
Yeah.
right there.
You notice that the title here, if you compare the title with what's in your program, it's slightly different. In the title, in the program, the original slide, it says equal risk reduction. And we sent this paper in, it's under review, and I got to revise and resubmit. But one of the comments the reviewer said that it's misleading to say equal because you had a differential dropout rate with more patients staying in treatment in the methadone arm than in the buprenorphine arm. So I think you really can't say it was equal. It was equal for the people that stayed in treatment, as you'll see as I go along here. And it's, as Andy says, is a secondary analysis of the START study, where the purpose was to compare, was to see if there was any evidence that buprenorphine caused liver damage. There were some case reports of patients on buprenorphine who had elevated liver enzymes, and so the question was raised, and the FDA basically asked NIDA to do this study. Disclosures for myself, these are, actually, I'm not a speaker for Reckitt Benckiser. I don't know how I got in there, but Reckitt Benckiser provided Suboxone for this study, and also for a study that we just finished in Tbilisi that got published in Drug and Alcohol Dependence a few months ago. The objectives of the main study, as Andy mentioned, was to compare changes in liver enzymes related to buprenorphine or methadone treatment, and then there were secondary purposes look at risk factors that could contribute to interactions with buprenorphine or methadone causing liver damage. And this is the background. There were, or some of the background, I think it's probably most of it, 11 case reports of hepatitis, transaminase levels markedly higher in patients with buprenorphine, but they also had hepatitis C. So this was the overview of the START study. Almost 2,000 people were screened for participation. Over 1,200 were randomized. And there you see that differential randomization to buprenorphine versus methadone, because the idea was to get at least 300 patients who kept, I think, 3 or more appointments and stayed in the assigned treatment for 6 months. And because of a differential dropout rate, they had to change the randomization from 1-to-1 to 2-to-1, sort of halfway through the study, so as to get enough buprenorphine patients that would be evaluable. And there you see the numbers for those who failed to continue and those who were evaluable in the two groups. And that was a significant difference. I think the averages were like 75% of the methadone patients stayed in this treatment long enough to be evaluated, as compared to about 45% of the buprenorphine patients. The primary outcome was changes in liver enzymes, and it was just descriptive, and there were these shift tables, you know, did it go up or down or stay the same in each group. And there are a bunch of secondary outcomes. Among them was HIV risk, was the topic that I'm going to present, and it was measured by the Risk Behavior Survey, which is self-reports of injecting and sexual risk behaviors over the past 30 days. And this was done for people who stayed in the study. I'm going to present just on the evaluable subjects, so we didn't get a follow-up study on people that dropped out. We just have the follow-up study on people who stayed in the study, and was baseline weeks 12 and weeks 24. And these are the participant characteristics. You had about 1/3 female, and the randomization worked pretty well. You know, equal females, average ages were equal between the two groups, and injecting was about 2/3, a little more than 2/3 in both groups. Again, ethnicity was about the same between the groups. So that randomization worked real well, which you would expect with such a large number of subjects. The baseline substance use, as you see, they were all opioid dependent, and that's the profile. It's primarily opioid. The next most common drugs were cocaine and cannabis, but you know, that was like 10-11%. The positive urine, it's just, you know, positive urine screens just goes along with what was said before. The opiates, and oxycodone actually it's an opioid, not an opiate, but that just reflects the selection factors, which they were opioid dependent. The dosing, these are the average doses of buprenorphine and methadone. Pretty standard. Actually, the average buprenorphine dose was probably a little bit higher than you get. The sort of modal dose, and correct me if I'm wrong about this, I think is around 16 milligrams. And so the average dose is a little bit higher, and I think that might reflect the fact that the programs would push the dose a little bit more to try to bump up that Suboxone, that differential dropout rate, and that there was sort of an aggressive push to make sure that the dosing wasn't a contributor to this differential dropout rate. These are the survival curves. It shows the differential treatment retention, and you had this very significant difference in retention. Again, keep in mind that these were patients that were coming to methadone treatment programs. This study had to be done in methadone treatment programs, so there could be some self-selection there of patients that have in their mind, you know, methadone, so they come to the program and then they're asked to give informed consent to be randomized. And what happened at our site, and I think a number of other sites, patients would agree to be randomized, knowing that, but in the back of their mind, they had an idea what they wanted. And so everybody had the experience of somebody randomized to Suboxone and dropping out very quickly because they really wanted methadone. Or, less common, but also happened, they would be randomized to methadone and drop out very quickly because they wanted to be on Suboxone. Opiate-positive urine drug screens were about equal between the groups. Cocaine-positive urine were, I think that's significantly a little bit more in the methadone and the buprenorphine group. And this is basically the topic here, the HIV injection risk behavior. With agonist treatment, you typically get a big reduction in injecting risk and modest reduction in sexual risk, and basically that's what we got here. You see a big reduction in needle sharing in the past 30 days among, again, among the completers, and that was equal between the two groups. In other words, for people that stayed in the study, you had equal risk reduction, but that differential dropout rate makes it impossible to say that, you know, they worked equally, but they worked equally if people stayed in treatment. And sexual risk, less, a significant reduction actually, but less than you find in the injecting risk, which is pretty typical with everybody else that's looked at these outcomes in methadone or buprenorphine treatment. And this is just a bit of a breakdown on specific items from the HIV risk instrument. And you know, you find big reductions in basically in the injecting areas. Sexual risk, you did find somewhat more reduction in sexual risk. It was significant in the methadone patients and in the buprenorphine patients. But the absolute differences between the two weren't a lot. We sort of speculated or theorized in the paper that this could be due to hormonal suppressant effects that you find with methadone and less with buprenorphine. The reviewers of our paper didn't like that comment either, so we got to modify that because some were women, and you know, and a third were women, and you know, the hormonal things can pattern. So we're working on that. So basically, the summary: there was a big and equal reduction in opioid injecting risk in both groups for patients who remained in their assigned treatment condition. There was an increase in the number of times amphetamines were injected in the buprenorphine patients. But again, this was the levels were relatively low. It wasn't a big effect because the overall level of amphetamine use was very low. Sex risk was low in both groups, but it was lower in the methadone group. And again, I put that consistent with the hormonal effects of methadone, but we got to change that speculation to, if the journals can accept our paper. And so if you consider the differential dropout rate, the conclusion is that across the board, at least for patients coming to treatment in methadone programs, methadone will give you better risk reduction, basically because more methadone than buprenorphine patients stayed in treatment. And if you consider only those that remained in treatment, they produced equal and marked reduction in injecting risk. And there could be a slight advantage to methadone in sexual risks, but actually that's an interesting, a number of years ago we did a study, when we first started methadone at the VA, we did this study, Jim Mintz was our statistician then, about sex risk, because the patients were coming in saying, that was when it was saying this is a plot against the African American community because they're just trying to make us impotent because by giving us this methadone. And so we looked at sexual risk, basically the sexual performance of people who came into the program and then after they've been on methadone for a while. And the findings were sort of interesting. When they came into the program, there were sexual problems, but they were more like premature ejaculation. These were all males, they were veterans. But then when they'd been on the program for a while, the complaints were impotence. So you did see that sort of shift. That paper was picked up by one of these outrageous magazines. And so we got a little kick out of that. But but, you know, what we found here was sort of consistent with that finding, but again, we couldn't really prove it. And so thanks to the Clinical Trial Network, this was a big effort, multiple sites, saw the sites, and went on over, what, Andy, 3 years, 4 years or something like that, you know? And so that's what I have to say. Thanks.
So we have time now for some questions and discussion before we move to the next speaker.
Yes.
People, please use the microphone because this is being recorded. I was supposed to tell you that at the beginning. And actually, we can say it now because there's a lot more people here.
Well, I'm very curious that so many more people dropped out of buprenorphine treatment. Yeah. And one of the questions I would have is, did you keep track of the complaints of migraines, nausea, weight loss, secondary to the naloxone ingredient, and were you ever allowed to use plain bup in any of your studies? I mean, the state I'm in, they want me to pretend that every male that says they have a side effect of the naloxone is just plain lying to me, but I believe them.
Yeah. Andy, I don't think there was a difference in side effects. This was for Suboxone. That's, you know, that was the study. It was Suboxone, not the mono product. Andy, can you comment on that?
Yeah, there were not any differences, marked differences between methadone and this was buprenorphine naloxone that we used in the study. And I just want to probably clarify the comment about the side effects being related to naloxone. There's very little evidence that any of the side effects from the buprenorphine naloxone combination are related to naloxone. The naloxone is only very, very minimally absorbed when taken sublingually, and it's been examined by looking at blood levels. They're vanishingly small, and it would be very unlikely for that to be causing any side effects. So the side effects, well, it shouldn't be getting into the gut unless people are swallowing it down. But there weren't any more complaints of GI problems in the study than what you would typically, they run in about the 10% range. So we'll definitely talk about the differential dropout rate as the day goes on, and certainly talk about that at the end. That's a very important point, but it probably was not due to side effects. And we did have a qualitative study looking at, and I can talk some about that at the end also, looking at what people said about why they stayed or left, and it wasn't related to medication side effects.
That comment about your people telling you they're all lying, you know, I just, right, you know, that's just a reflection of prejudice, I think, you know, I mean, you know, if they say that's what they have, that's what they have. I mean, methadone patients will sometimes complain about, you know, sedation, they don't feel quite right. Some patients will say they feel better on buprenorphine. It's all over the place. Yeah. Yes. Hey.
Nice study. Just a question. You mentioned the sex risks weren't high to begin with.
Yeah.
Why do you suppose that is?
Good question. I don't know. It's just the way it was. I really don't know. You know, the other drug use will vary according to the locale. In one of the things you find with methadone, at least in this area, we've looked at it, you know, a lot of benzodiazepine use, and actually that can sometimes even go up when they're on methadone because you will get that interaction, you know, between the methadone and the benzodiazepines, where the patients say the benzos will boost the high, particularly the rapidly short-acting ones like alprazolam or diazepam. But I'm not sure. That's just the way it was. Yeah. I'm not sure if we looked at it according to site, Andy. You look at that as a function of sites because you do have differences in other drug use patterns among the sites. The other drug use, the other drug use was relatively low. You know, if you look at a methadone program in Philadelphia, you will find, look at urine tests, you sometimes you'll find 30, 40% were positive for benzodiazepines. And in this study, the other drug use was lower.
Yeah, I think certainly what we saw there is very consistent with what we see with patients coming into treatment in Seattle. So there was a 30 to 40% rate of cocaine in the urine at the time we got the urine, and the benzodiazepines were around 15%, and cannabis around 15%. So at least in Seattle, that's pretty typical.
Yeah.
There are regional variations, and this was at 8 sites around the country. So yeah, I think that's what we saw.
Yeah. Others? Okay, thanks a lot. Andy? Okay.
So next we have Petra Jacobs from the NIDA Clinical Trials Network, and she is going to be presenting on the induction trajectories with methadone and buprenorphine and how they affected some of the outcomes. So, Petra?
Thanks very much, Andy, for the introduction, and also thanks for very nice overview, like basic overview of the START main study. Again, my name is Petra Jacobs, and I am the Assistant Director for the Center for the Clinical Trials Network at NIDA. And I have been working with Andy, George, and with other researchers as the scientific liaison for the START study, for the original study. But today, I'm going to present you something new, our project, very exciting, and that's actually fun part of our work when we start asking those questions that you just asked during the discussion. And we will look for the answers right in the database. And I want to say that START actually database has a very rich data, and those data are available online. So your questions that you raised actually could be looked at and find the answers, or at least suggestions of the answers from those data. So our group, and you see here all my CTN colleagues that were working with me on this project, we're really interested in induction part of the START. We were really trying to, find, we know that that induction is the most critical or crucial part of treatment with methadone as well as buprenorphine. So we were really trying to find information that would help us with a clinical implications or some further research that would improve induction and keep people in treatment and keep them opioid free. And first, of course, we had our hypothesis. And our hypothesis was that before we start doing the analysis, that participants that will be on higher buprenorphine or higher dose methadone and buprenorphine induction strategies or faster induction strategies will be doing better, will have better outcomes, because we hypothesize that perhaps they will have their problems with withdrawal symptoms addressed earlier and better. They will feel more comfortable, so they will not need to use drugs, and they will stay in treatment. Another, of course, factor that we looked at was the side effects of the medication, because, of course, we consider patient being successful not only having lower opioid use and staying in treatment, but, of course, also having less side effects from the medication, which We also, the START study, collected this data on related adverse events. We looked at everything that was mentioned here, like drowsiness, constipation, and others. And for us, successful treatment, we would have found patients having lower opioid use, higher retention, with no more adverse events in those induction strategies that we were looking at that. Also, our second question was if higher 2-hour post-induction withdrawal score is associated with higher dose trajectories. And I think that we just wanted to confirm, or we just wanted to take a look how these patients were dosed, because according to the protocol, clinicians should have been dosing patients very flexible according to their withdrawal symptoms. So we wanted to take a look if really this happened in this trial. And you see here the sites, all our heroes that were working with their patients and randomized patients in the study. The reason I'm showing you this slide is really that these are opioid treatment programs that treat patients that seek treatment for their opioid addiction. So these are no pain clinics, no primary care offices, so these are the clinics that are receiving patients with opioid addiction, because we also got comment from our reviewers saying, well, you need to make sure to explain your audience that the data they are looking at are data of patients that are not opioid naive. They have dependence on opioids. And they developed a tolerance to opioids, because otherwise it can get misinterpreted. And we already had some of it in the past, I think, of the discussion. And all of these treatment programs, I'm sure that you know them all, have decades of experience with prescribing methadone to opioid-addicted patients. So, of course, we were very happy about that. And you see also where these sites were located, with what nodes or universities they were working on this research study, I mean on the original START study. And this is really the background, where we were coming from, how we generated our hypothesis. We know, all of us, that buprenorphine, naloxone, and methadone are effective treatments for opioid addiction. We have huge or extensive research proving its efficacy. And we have clinical practice that confirms it. Methadone, for our international colleagues, has been available in the United States to treat opioid addiction since 1960, and buprenorphine since 2002, again for treatment of opioid addiction. However, we don't have so much data about what is the best way to induct patients on those two medications. We do have one small-scale study that Dr. Greenwald, bless his heart, that did in 2006, and he compared rapid methadone induction with stepwise methadone induction. And he found out that the higher methadone dose he had in the study, the lower craving participants experienced towards heroin. But this was really a small-scale study, and was designed for a little bit different purposes, and they did not mimic current clinical practice in terms of how buprenorphine and methadone is inducted in community treatment programs. And there is another factor that influences dosing of our participants or our patients. And Dr. Pollack described it in his paper as he found that stigma, managed care stringency, and also financial resources predicted lower methadone dose in his study. And that's really a reason why we wanted to take a look at the STAR data, because the data we had really were what's going on in opioid treatment programs, how these patients are really get inducted, and we wanted to take a look at how these different induction strategies work, what are their outcomes. And this is our study design, and I will just repeat it. START study randomized 1,269 participants, 700 in buprenorphine group because of the change of randomization scheme. This number is bigger than this number, 529 methadone participants. For the purpose of our project or our study, we analyzed the data separately. So we were looking at the different induction strategies within the methadone, within the buprenorphine group, and then within the methadone group. And here, according to the protocol, patients should have been inducted on buprenorphine within the first 4 weeks. And then they were treated for 6 months with methadone or buprenorphine that were provided by Reckitt Benckiser buprenorphine and by clinics methadone. So those patients were receiving it for free. And again, our main focus of the study was on the first 4 weeks. And here are the dosing recommendations that clinicians received before the study started. So clinicians should have instructed participants to abstain from opioids for at least 12 hours and come in mild or moderate withdrawal, which means that their COWS, their clinical opioid withdrawal scale or score, should be more than 8. In buprenorphine arm, you see this buprenorphine dosing. On day 1, participants were dosed with 2 to 8 milligrams of buprenorphine in the clinic. They were observed within 2 hours, and then if their COWS was more than 5, they could get another dose, and they could get up to 16 milligrams first days if appropriate. On day 2, the dose could be adjusted again against the withdrawal symptoms up to 32 milligrams, although as you will see further when I show you the trajectories that we got, not so many patients got into 32 milligrams. And then, of course, the rest of the study, patients should have been against their withdrawal symptoms and craving up to the end. And here is the methadone dosing recommendations that clinicians received. And again, those clinicians had decades of experience with methadone. So dosing, again, was allowed quite flexible based on patient need. And they did get, of course, instructions to abstain from opioids. And maximum dose, as here in the United States, is 30 milligrams with, and patients then were observed within 2 hours with a limit 40 milligrams that is here regulated by US regulations. If COWS was more than 5, they got another dose up to 40 milligrams per day. On day 2, they could go higher by 10 milligrams, and day 3 too. However, not so many of them did it, as I will show you those trajectories, which was again allowed by the protocol, by the study protocol, as investigators allowed clinicians really to use their physician's judgment and go slower if they seem to need it. Outcome measures that we looked at are opioid use. We looked at timeline follow-back, which is a self-report that look at the previous month's every day of opioid use, and we confirmed it with urine drug screen, which is more objective measure to capture opioid use but already now I can tell you that both the results, or results from both measures collected were very consistent, were practically the same. Also, we looked at the retention, which we defined as number of days receiving medication starting day 1, and most importantly, adverse events that were collected through adverse events and serious adverse events forms. And we were looking at the rate of participants with study-related adverse events. Withdrawal symptoms were collected here through COWS, Clinical Opioid Withdrawal Scale, 2 hours after first dose. And before we started the study or the project, we were hoping that the COWS was collected first month each week, but then we found out that it was not that. So we just had this 2-hour post-initiation COWS, which is, limitation when you do secondary analysis. It's very exciting, but of course sometimes you just need to get to the data or use the data that are available. And our statistician used multivariable models to analyze the data. You see that for each outcome, he was using appropriate method based on the kind of the outcome and the data, outcome data. Covariates were baseline participants' characteristics, considered via propensity scoring, and also site was entered into the model as a variable. And we were interested, of course, to see trajectories and if there are, or those induction trajectories, and find out if there are any difference between them. And here again, those are the baseline participants' characteristics that we adjust for: demographics, age, gender, race, baseline COWS score, baseline opioid use, baseline route of drug use, intravenous or not, a baseline psychiatric comorbidity, and pain, which we know that also they can influence the outcomes, and we wanted to control for them. And here are the trajectories. And that's what we got from statistical analysis or by statistical methods. So these different trajectories, I just want to clarify again, patients were not randomized to these different trajectories. These trajectories that we got were based on the statistical methods, these longitudinal exploratory analysis. And you see, interestingly, that 3 trajectories started here at 15 or 16 milligrams. This is a mean dose of buprenorphine. And the highest dose trajectory went up first 3 days up to maybe 28 milligrams of buprenorphine, and then went down to 22 at day 28. So this was the highest dose trajectories for participants that get highest dose of buprenorphine. Second highest was this buprenorphine 5, so it's labeled from 1 being lowest, 6 the highest. Second was this one, buprenorphine 5, where participants started on a moderate dose of buprenorphine first day, then went a little bit up to 16, and then maintained their 16 all the way first month. And here, and third was here buprenorphine 4, that we still are looking for more interpretation about what happened to these participants. And buprenorphine, but you see that, or I think when we looked at these trajectories, we were saying, these 3 trajectories really ended up above 16 milligrams of buprenorphine, which really is considered, according to Greenwald's research, that and 16 milligrams in patients, usually 80% of their immune opioid receptors should be covered or should not be available. So maybe 16 milligrams is, I'm sure that you heard it from some clinicians or from trainers, maybe enough for treating patients with opioid addiction, because it covers their immune receptors. And I think the difference between 16 and 32 milligrams, I think that 32 milligrams, I think, should decrease the availability of mu receptors by 84%, if I'm correct. So it's really not big difference in laboratory between 16 and 32 milligrams. But here what we saw is that really this group needed more than 16 milligrams, at least here, and then by the end of the induction or stabilization as well. So we do have a data showing that part of the participants really needed more than 16 milligrams, which may be a problem, as I learned from my colleagues that prescribe buprenorphine to patients that have opioid addiction, because they may not be reimbursed for buprenorphine dose higher than 16 milligrams per day. But again, here is the information that some patients needed. And it was quite a pretty big group, you see here. Buprenorphine cis group, it was about 16% of the sample, 114 people. Yeah. Yeah, so when we looked at this graph, we were saying, okay, well, it looks like these guys, or these three trajectories really started on a low dose of 8 milligrams, then went a little bit up. And the lowest was this buprenorphine 1 trajectory that started at 8 and continued really all the way 8 milligrams. So any guesses what trajectory had the best outcomes? I will show you later on. And as you see, each group had quite nice number of participants, so we can take a look at the data and see if there are any differences between the trajectory outcomes. And just for fun, this lower, this lower dose trajectory had 25% people on. Okay. Here. And here are the methadone induction trajectories that we got. We got 3 main trajectories of induction on methadone. And here you see that these 2, methadone 1 and methadone 2, this is the lowest one, started at about 30 milligrams as we know and expect, and then went up to 40 and continued 40 up to the end, which is up to the end of the induction and stabilization according to the protocol, day 28, which is really below what we consider as effective days of methadone, which is 50. But again, these participants, these were not randomized to 3 different trajectories, so we really don't know what happened here with these participants, if they were in higher risk, for example, for side effects. I mean, a higher risk, I don't know, using benzodiazepines, or why didn't get higher with the dose. So we would still need to take a look at the data. And methadone 2 went gradually up, nicely up to 80, and I would think that's what you see in your opioid treatment programs. And methadone 3 guys started on 40 milligrams and went up to 100 milligrams. And here you see that again we had nice number of people in each of the groups, so we could do the analysis and look at if there are some differences in outcomes of those patients. Ta-da! This is buprenorphine, what we got. And here you see, and we were a little bit disappointed that we don't see more difference in terms of opioid use for 7 days in the buprenorphine arm, because you see that buprenorphine 1, which is the lowest, and buprenorphine 6, really, there was no significant difference in the number of drug-using days. And medium range was, and this is actually from raw data, 1.8 to 2.6. So those participants during the first 7 days usually used 2 to 2.5 days of opioids, which we were a little bit surprised, thinking, well, buprenorphine blocks the effect of heroin. So it's interesting that they keep continuing doing this behavior or using other drugs. We didn't find any difference in the number of opioid using days among all those 6 buprenorphine groups in first 28 days. However, we did find difference in buprenorphine 5 number of opioid using days and compared to buprenorphine 1. So buprenorphine 5, if you remember, that's that group that started on moderate dose on 16 milligrams, median moderate dose, and then they stayed on this 16 milligrams all the way during induction and stabilization. And our guess and fabulation, maybe not true, or hypothesis. Our hypothesis is that maybe buprenorphine 5 guys are those guys that need more, that their maintenance dose perhaps is around 16 milligrams. So they got very quickly on 16 milligrams and stayed on 16 milligrams. So that's why they were doing better than these low buprenorphine dose group. But we really don't know. This is just hypothesis. Retention, interestingly, first 7 days was different across the groups. You see that buprenorphine 1 group, which is that lowest dose group, participants were 3 times more likely to drop out than in buprenorphine 6 group, in that group that had highest loss of buprenorphine. So this was in the direction that we hypothesized. Retention in first and last 28 days across group was similar, so it looks like retention first 7 days, and dose during the first 7 days is the most important. Again, interestingly, and we were happy to see that there were no differences in number of related adverse events across the groups. So participants in those groups that received higher dose of buprenorphine really didn't have more adverse or side effects than those in low dosing groups. So to summarize, I think that we would say that there may be the slight advantage of having patients on higher dosing groups in terms of retention. It doesn't look like there is disadvantage because the rate of adverse events was similar across the group. And just to notice, COWS groups, or the COWS was different, higher. As we expected, the higher dosing groups had higher COWS than these low dosing groups, 2 hours post-initiation. And here are the Methadone findings that are actually a little bit stronger than we expected. And you see that there was a significant difference between Methadone 3 group, which is the group that got the highest dose of methadone, and Methadone 1 with that lowest dose of methadone, because Methadone 3 guys were using opioid less than Methadone 1 guys, with medium range 3 to 4 days. Again, we saw difference in opioid use across these 3 groups. Methadone 3 had less opioid using days than Methadone 1. Methadone 2 had less opioid using days in Methadone 1 first 28 days. And regarding last 28 days of treatment, which is the last 28 days of 6 months, Methadone 3 had less opioid using days than Methadone 1. So and the participants in Methadone 3 group dropped out less than participants in Methadone 1. And again, we were happy to see similar number of adverse events across the group. So there was really no disadvantage of being in this high-dose methadone group in terms of having adverse events. And regarding the COWS, we saw that methadone 3 group had higher COWS or higher withdrawal scores than methadone 1. And of course, here I need to admit all the limitations of our findings and study when we interpreted them, because this was secondary analysis. So as I mentioned several times, participants were not randomized to different dose trajectories within methadone or buprenorphine group. So there is possibility that something else was going on there, like for example, benzo use or other. But what we can say, I think, is that participants that were in higher dosing groups, especially in this methadone 3 group, were having better outcomes than participants than in methadone 1 group. So again, study population were mostly methadone clinics patients coming to OTPs every day. So we don't know if we would get different results in physicians' offices, because I think that we have some data showing that methadone or patients that are coming to methadone clinic have different severity or have high severity of opioid addiction, a different SES. So it's so when you think about the results, I think clearly opioid-addicted patients, again, no opioid-naive patients, opioid-addicted patients is more that are coming to methadone clinics, I think would be most appropriate for its interpretation or for using these results. We also didn't look in this project how COWS score changed from baseline to 2 hour post-initiation, because we just didn't think about it before we analyzed the data, and so we didn't include it in our pre-specified hypothesis. And we already had so many analyses going on that we didn't want to add to that mix. And that's the last limitation that I will mention today, that multiple analyses were performed, so really p-value close to 0.05 may be questioned due to multiplicity. To conclude, STAR participants, as you saw, were inducted in 6 different buprenorphine induction trajectories and 3 different methadone trajectories. Again, our hypothesis is that maybe since those were methadone programs that were having decades of experience with methadone, maybe methadone induction strategies are more standardized, so less variable in those methadone clinics compared to buprenorphine, because some of those OTPs never used buprenorphine before the study. And of course, buprenorphine started its implementation here in 2002, so there may be still a higher variability in how it's being used for induction. And the other conclusion, of course, participants confirmed our hypothesis that participants in highest dose and faster induction trajectories as buprenorphine 6 and methadone 3 were overall more successful or having more successful outcomes while having similar rate of adverse events than participants in low dose trajectories. Also, participants in those moderate dose trajectories, as buprenorphine 5 or methadone 2, were also more successful than those participants in low dose trajectories. We saw, again, as we expected, that a higher 2-hour post-induction COWS score predicted higher buprenorphine and methadone dosing. So it really looks like clinicians were using their withdrawal symptoms of their patients to dose according to or to address their withdrawal symptoms. But again, in order to written this in stone, we would need randomized clinical trial comparing different induction strategies to really avoid confounding, which was possible here. And it would be actually interesting to look at specifically those participants or those patients that are coming to opioid treatment programs with high severity of opioid addiction, because maybe they do need higher buprenorphine doses, especially during the induction, and how high and how, we don't know. Yeah, we don't know. Ed is like shaking his head. He doesn't believe it. But we really don't know unless we have the study. So thanks a lot to all the CTPs, all the investigators that participate in such huge effort, and of course to the patients that were willing to be randomized to those two different arms.
Hi, my name is
Hello.
Ingvild Olsen. Excuse me, and I have a bad cold. So I thank you. This is really one of the things that I have been searching for, the literature, particularly on the methadone side, because I go by Tom McClellan, or the study that really randomized at Bayview high dose versus low dose methadone, but there's nothing that has really helped me guide kind of that initial induction period.
Yeah.
So I really appreciate this.
Thank you.
My one question is, do you have data, or is there a possibility to look at the first 7 to 14 days of the methadone induction group? Because I was always taught that because of the pharmacological profile of methadone, that increasing doses day to day by even 10 milligrams a day can be very problematic because of then the accumulation and kind of the buildup that you get. And so I'm now very leery, I guess, about doing that, and whether or not there's data, particularly in that initial period, to kind of help guide us in that.
Mm-hmm. Oh yeah. And I think that if somebody, maybe George would, I think, jump up, because I think he had the same concern. And this was actually, yeah. So, first of all, we don't have the data. The literature that I found regarding those first days was actually Mary Jean Creek in 1977. She published that her recommendation of course, starting low, 30 milligrams of methadone, and if needed, 40, as we know. But also, I found that she suggested having increasing every 4 to 7 days methadone dose up to 10 milligrams, according to patients' withdrawal symptoms. But that's the only thing that I found. So again, that's the reason why we wanted to take a look at that, see, because the data that we have, well, we know about the risk of methadone. We know about the long half-life, that is 36 to 48 hours, and in some patients even longer. So of course we are concerned about the overdose or about the respiratory depression if the dose of methadone is being increased faster than opioid tolerance is being developed. So yeah, that's a big concern. And again, we don't have data about that on that. So the data from this study, again, we were lucky to work with those opioid treatment programs that knew what they were doing, because they have been doing for decades, and they were inducting patients safely. Yeah.
I'll just say, if you want to do an RCT, our OTP is happy to participate.
Oh, thank you. We love working with OTPs. Yeah. And here is, and actually I just wanted to show you again, because I think that this is the critical picture, how our OTPs are going on with inducting the patients. Yeah. And again, since of this concern that you mentioned, increasing the dose of methadone slower, these physicians in the trial did have this leeway to use their physical judgment, yeah, because we didn't want to push clinicians somewhere where they were not comfortable.
I'm curious if you had data on the distribution of these trajectories across the different clinic sites. It seems to me that if it was distributed evenly across the sites, that would be more based on clinicians assessing what the patient's needed as opposed to clinician idiosyncrasies.
Yeah, actually we do have a data. I don't present them here, and it was surprisingly quite evenly distributed. Yeah, so we did include, I think, site as a covariate into the analysis, but when we look at that, if some trajectories were represented in different sites differently, we didn't find something that would be like mind-boggling. Yeah, it was pretty evenly distributed. Yeah, and do you want to add something about the safety of methadone?
No, actually, I'm going to move on to our next speaker so we stay on topic, but I will say that Matt Hickman and John Strang in the second half, I think, are going to present some data relevant to this question of the first couple weeks of methadone, and then I think we can have a vibrant discussion, all of us, at the end, because I think there are some unknowns there that are very important. And so now I'm going to introduce our next speaker, Richard Christ, who's here in Philadelphia at the University of Pennsylvania, and he's going to be speaking about the pharmacogenetic data that we so far have discovered from the START study.
All right, can everyone hear me? Guys speaking to this thing? So my name is Rick Christ, and I'm a postdoc in Wade Berrettini's lab at the University of Pennsylvania. And our lab primarily works with genetics of psychiatric disease, including addiction. And we were asked by the START clinical trial folks to do pharmacogenetics of methadone and buprenorphine. So, we got this thing. Okay, so first I just want to go over quick disclosures. I was supported by a couple of NIDA training grants. My boss, Dr. Berrettini, also has several NIDA grants that funded this. And we were also funded through the START clinical trial Delaware Valley node. Through the Clinical Trials Network. So this might be a bit of recap for a lot of people here, but over here is sort of the opioid receptor signaling pathway. And what happens is people take heroin or prescription opioid painkillers, and they act as agonists, and they bind the opioid receptor. You get this downstream signaling, and you get the rewarding effects of the drug use. And we know that there's several FDA-approved drugs. We've already talked today about methadone and buprenorphine. There's a couple of other ones. Methadone acts also as an agonist of the mu-opioid receptor, which is a member of the opioid receptor family. There's a couple other ones. There's the kappa and delta opioid receptors. And we're going to talk about the delta one later today. The buprenorphine in comparison to methadone is a partial mu agonist, but is also an antagonist at the kappa opioid receptor. And the main point here is that we know these medications do work better than placebo, but there's a slight caveat to that. And the caveat is that they work better on average, but they don't work in all people. And really the question is, why don't opioid addiction treatments work for everyone who comes into the clinic? So in case you didn't believe me that they don't work for everybody, this is just some data from 4 clinical trials from the 90s and early 2000s. And there's a lot of variety in here. They have buprenorphine, they have methadone, they have them at different doses. They have them, there's different ethnicities, they take place at different sites. But what you can see is the one common thing here is that when you test urine samples for the presence of opioids other than the one prescribed, roughly 50% of them come back positive. So half the time, roughly, the drugs really aren't doing what they're supposed to be doing, which is preventing people from using illicit opiates. Now, the question is, why is that the case? And there's a couple of reasons why people sort of fail in treatment. One of the ones that I'm not really going to get into is just sort of the unrealistic definition of failure. If you're looking for abstinence as your only marker of success, you're probably not going to get a lot of people that meet that requirement. However, if you're talking about, say, reduction in use, say from daily to once a week, you might get more people that way. So that's why, for the most part, in the stuff that I'm going to talk about today, we're using opioid positive urinalysis data, so we can see a reduction as opposed to just pure abstinence. But there's a couple of reasons why people do fail in treatment. It's been shown for a while that there's a lot of environmental factors that go into success in opioid addiction treatment and addiction treatment in general. If you have a higher level of education, if you come from a higher socioeconomic class, you're more likely to do better in treatment. If you have personal relationships that are negative factors, those can really affect it. If you're related to drug dealers or drug addicts, you have friends who are drug dealers or drug addicts, you have a much lower chance of succeeding. Meanwhile, if you have a nice support network, you have a much better chance of succeeding. And again, depression, if you're depressed, you're less likely to do well in treatment. And this is just sort of the tip of the iceberg. There's a lot of environmental factors that can affect how well you do in treatment. But environmental factors don't really explain everything, and that's where genetics comes in. And the idea here is that there's genetic variation between individuals, or polymorphisms, and that can affect not only how well the treatments work, but also side effects, which you can imagine can also affect how well your treatment outcomes are. If you have very deleterious side effects, you're probably more likely to discontinue use and have a bad treatment outcome. So in this incredibly simplified clip art picture, this is just pharmacogenetics in a nutshell, which is just the meeting of pharmacology and genetics. And what generally, in a lot of situations, we have this sort of monolithic block of patients, and we give them a treatment for whatever ailment they have, and it works for some people and it doesn't work for other people. And those are the breaks. And we do that for a couple of reasons. In some cases, we don't have a second treatment to give them. There's no other option. But in a lot of cases, we do have other treatments, and we just don't know why we should be giving them one treatment versus the other. Pharmacogenetics is trying to fill that void, in which it's not really a monolithic block. In this case, it's actually, there's some green people and there's some blue people, and I realize that doesn't equal yellow when you add it up. But in the green, here, the blue people, when you treat them with this treatment, they have a 100% success rate. The green people don't succeed at all. And this is obviously a highly simplified version of this, but you can imagine how having this information would be really important, because you can know ahead of time which people are going to have a higher rate of success in the actual treatment. So that's the theory in general, but it's not actually just a theory. We have seen pharmacogenetic effects before. And one of the big ones is the cytochrome P450 family of genes, and this is a family of enzymes. They break down a whole host of medications from active forms to inactive forms. And you can imagine how if those enzymes are working at a better rate than average or a worse rate than average, that can affect how much medication you should be prescribing people, how much medication they need to have a good outcome. So, for example, if you're giving people 2 tablets of this imaginary drug and they're poor metabolizers, so their enzymes don't work really well, you don't have to give them as much because their body's not going to be breaking it down. And in fact, if you gave them the regular dose, it'd probably build up at high levels in their bloodstream and they'd have negative side effects. Meanwhile, on the other side, these ultra-rapid metabolizers, or people who have really good enzymes, as soon as you give them the medication, it's just their body's clearing it out. So you need to give them more ahead of time. Now, we know these genes affect just a whole host of medications, one of which is methadone. And I'll mention that again in a second here. But this is just an example of pharmacogenetics isn't just a theory. We are starting to see actual effects that do affect people when they come in for treatment. So pharmacogenetics is a relatively new field, probably a little bit over a decade right now when we've really started getting into it. And there's not a lot of findings in addiction, frankly, or at least not a lot of findings that have been well replicated. So I'm going to go through pretty much 2 of the ones that have been looked at the most, and then get into where we are with opioid addiction here. So in alcoholism, people are often treated with naltrexone, and that's a mu-opioid receptor antagonist. And we know that there's a coding polymorphism, so a polymorphism in the mu-opioid receptor gene that affects the protein structure. It's called A118G. And if you have the G allele, people seem to have a decreased risk of relapse. So here, the further down these lines go, the more people are relapsing to heavy drinking. And this line up at the top that separates from all the other ones is people on naltrexone who have the G allele. And this finding's been replicated a couple times in a couple different ethnicities. A118G has also been linked to nicotine for nicotine replacement therapy, so gum, patches, I think nasal spray actually in the case of a couple of these papers. And people with the G allele have increased abstinence rates. Now we're getting into sort of, a lot of people have looked at this, but hasn't been really replicated that well. In one case, I think they actually found exactly the opposite effect. So with that in mind, if those are two of the more well-replicated findings in pharmacogenetics and addiction, you can imagine there's not a lot going on with opioid addiction at the moment. We do know that a couple of the cytochrome P450 genes, as I mentioned before, do break down methadone. I think it's CYP2D6 and CYP2B6. And ABCB1 and DRD2 have also been associated with the dose of methadone that you need in treatment. However, it's not entirely clear how much that actually matters for treatment outcome, because in flexible dosing schemes, you can just give them more methadone if they need it or less methadone if they're having negative side effects. Meanwhile, buprenorphine hasn't been linked to a whole heck of a lot. So the problem you're seeing here is that these pharmacogenetic findings in addiction really haven't been replicated well. There's not a lot of them to go on, and that leads to currently there's no FDA-approved pharmacogenetic basis for selecting addiction treatment. So that's sort of the holy grail that we're looking for right now, is a reason to give people one treatment versus another. So that brings us to the START clinical trial. You might notice off the bat that our numbers are a little different than the other people that have presented already. And this is because we actually had to have DNA for them instead of just the outcome data. So we did have DNA for 566 European Americans and 77 African Americans. We analyzed these two groups separately, which we think makes sense because if you're assuming that genetics can have an effect on how well the drugs work, you probably want to get rid of the gigantic confounding variable of having completely different genetic backgrounds in the two ethnicities. Again, this was 24 weeks of methadone or Suboxone, which is buprenorphine and Naloxone. I'm just going to refer to it as buprenorphine for the rest of the talk. And our outcome measure was weekly urine drug screens for opioids other than the one prescribed. So if you're taking methadone, we don't care if you're testing positive for methadone. In fact, we hope that is the case. Importantly here for our analyses, we excluded the missing tests. Now, if someone is in opioid addiction treatment and they don't show up repeatedly for treatment, it's probable that they're using illicit opiates. You don't know that 100%, so to be more conservative, we did exclude them from our analyses instead of counting them as positive. As an aside, it didn't really affect the outcome. So as I mentioned, methadone is a mu opioid receptor agonist, and buprenorphine has effects at the mu opioid receptor and the kappa opioid receptor. So naturally, we're going to talk about neither of those and talk about the delta opioid receptor, which is OPRD1. Now, there is some reason why we would actually be looking at this gene. The mu opioid receptor is well known for regulating the rewarding effects of opioids, but the delta opioid receptor also regulates those rewarding effects. In addition, recent papers have shown some associations between methadone and buprenorphine and the delta opioid receptor. So methadone can signal through these complexes that the mu and delta opioid receptors form. And buprenorphine has been known for a while to have a high affinity for the delta opioid receptor, but we don't really know what that means or what it's doing, if it's doing any sort of signaling downstream. So at the bottom here, you can see the, a figure for the delta opioid receptor gene. And we genotyped 6 SNPs, or polymorphisms, across the gene. One coding SNP in exon 1, one in exon 3, and then a smattering in the large intron between exon 1 and 2. So for our statistical analysis, we used the average percentage of opioid-positive tests over the 24 weeks. So how many times out of those 24 urine tests did they test positive for opiates? And we did it a couple ways. One, we did a logistic regression, which you can see here is just on this treatment, they did worse on genotype A, they did better on genotype B, and that slope is your effect size. I'm not going to really go into that much, but comparing that to the gene by environment, which I am going to go into, the gene by environment interaction, instead of looking at is there an effect of genotype on treatment, you're looking at is the effect of genotype on treatment different between the two groups. So what you can see here is that in treatment X, they're doing better, or they're doing worse on genotype A, better on B. In treatment Y, it's exactly the opposite, and the difference between those slopes is the effect that you're looking at in gene by environment. So we did our gene by environment analysis on the European Americans, and sadly, there was nothing significant. Although as a minor aside here, there was a paper that our lab published recently from another postdoc that looked at European American women, and that she did find an effect in the delta opioid receptor gene, but I'm not going to talk about that too much today. I am going to talk about this, however. When we analyzed the African Americans, we found a highly significant p-value for the gene by environment for an intronic polymorphism, RS678849. So, as I mentioned, that last analysis used the average over the entire 24 weeks. But since we have the 24 weeks of data, we wanted to look at this in a more longitudinal way. And we did that with the help of Alfonso Ang, who is a statistician at UCLA and was involved in the START clinical trial. And Alfonso ran a generalized estimating equation for us. And that's a kind of linear model where you can take into account the effects of a number of variables and sort of configure your p-values based on that. So we accounted for the effects of age, for sex. He did location at one point, although that didn't enter into the final analysis. Cocaine dependence and max dose were all included in our analysis. So when we looked at these separately, methadone over the 24 weeks was significant. Buprenorphine was significant, but again, when you look at the gene by environment analysis, you're seeing a very significant p-value in the 10 to the negative fifth range. And when you look at the figure here from the paper, which I believe is in all your packets, you can see this, why that makes sense. On the x-axis here, you're seeing the time in weeks. On the y-axis, you're seeing the average percentage of positive urines. So higher on here is worse, and lower is better. They're not using as much. In the methadone arm, starting around week 10 to 12, people with the CC genotype, shown here in light gray, start doing significantly better than individuals with the CT or TT genotype. But in buprenorphine arm, it's exactly the opposite. Individuals with the CC genotype, almost from the first week, are doing significantly worse than people with a CT or TT genotype. So looking at each of these separately, you can see why they might be significant. But the fact that the effect's exactly the opposite is why the p-value is so significant for the gene by environment analysis. About that. So the first question you might have is, so okay, we got this significant finding. What does this polymorphism do? And the answer is, sadly, we don't really have a clue what it does. It's right here. It's in a very large intronic region, and intronic polymorphisms have been shown to do things before, have functional effects. They can regulate expression of the gene they're in. They can regulate alternative splicing, and they can do other stuff in addition to that. But we don't have any functional data yet. The hope is that down the road we'll be able to figure that out. But despite the fact that we don't have any functional data for this SNP, it has been linked to not only addiction but other brain phenotypes previously. So we published a paper earlier this year showing an association between this polymorphism and cocaine addiction in African Americans, although oddly enough not opioid addiction. It was also linked in another paper to just general drug dependence in a population of African and European Americans, and it was linked to relapse rate in smokers that were treated with naltrexone. So it has been linked to addiction phenotypes before. Additionally, there was a paper published this year which showed that the C allele of this polymorphism was associated with smaller regional brain volume in the frontal, temporal, and occipital regions of the brain. And that was in healthy adults in their 20s and healthy elderly adults as well. So it's a very interesting finding. Additionally, people with the CC genotype had a higher level or higher ratio of tau to beta amyloid, and both of those have been thought to be markers of Alzheimer's disease possibly. So although we don't know specifically what RS678849 does, it does seem to be a where there's smoke, there's fire situation where it's been coming up repeatedly in addiction findings and also brain findings. So it seems to be doing something interesting in the brain. We just have to figure out what functionally that is. The other question you probably would have if you were reading this paper or listening to this talk is, why is the effect only seen in African Americans? So I'm going to get to the caveat of these findings on the next slide, but I think I'm just going to start with the most obvious one. The most obvious one is that there's genetic differences between African Americans and European Americans, and they affect a vast array of phenotypes, and that can be something as simple as skin color, and that can be something much more interesting, like, for example, the effectiveness of beta blockers, which don't work in a subset of African Americans, or don't work as well because of a genetic variant they're carrying. So you can imagine that with a number of genetic polymorphisms between the different ethnicities, there's just going to be some by chance that affect medications. And so this really sort of highlights in the future, it's important to at least use it as a covariate and most likely do what we did, which is separate out the ethnicities entirely so that you can find effects that affect each one separately. So that was why we think it happened. The other option is that this is a relatively small sample size. So if you remember back to the beginning, we had 566 European Americans, and we had 77 African Americans. And really what that small sample size of the African American highlights is that we need to replicate this in an independent sample. Realistically, we would have had replicated anyway, but this is a small sample size says that we could have a slightly higher chance of having a false positive. So something to keep in mind. There's a couple ways we could replicate. We could do a new clinical trial, which, as you've already heard today, would cost a lot of money and take a lot of time and might not happen. But we would love if that happened. And the other way, which would be cheaper and take less time, is to use current populations of methadone and buprenorphine patients who are on maintenance. So these individuals often have to give urinalysis data either weekly or monthly to show whether they're using opioids or not. So we could just get funding to get permission to draw their blood, check their DNA, and see how that lines up with their urinalysis data. Now, there's a couple of issues with that. One that we've heard about repeatedly here is the dropout rate. We got people for a 6-month period in the START clinical trial. If it's unknown how long some of these people have been on methadone, if we go to like a methadone clinic, they could have been on it for years, which means that the snapshot we're getting when we get their data might not be the same as the people who are newly starting in, say, a clinical trial. So some of the people may have already dropped out and we won't have their data, which might affect the end results. The other problem is that the time on the medication may affect the outcome. We really don't know what will happen if someone's on it for more than 6 months. So if they're on it for years at a time, whether that will still, the genetic effect will still be there. So it's something to think about. There's pros and cons to both of them, but as I said, it's going to be hard to get the Clinical Trials Network to fund another study, son or daughter of START. So I just want to wrap up with sort of how this would be effective in the clinic and how not just our findings, but just all sort of pharmacogenetic findings. So this is the cartoony version I showed you before, and this would be interesting information. It'd be good to know that the green folks aren't going to do very well, and if you have a second medication, you can give them that medication. But again, that second medication is, again, just a crapshoot. You don't know for sure whether it's going to work or not based on their genetics. So what we've actually described here is a slightly different situation in which we have 2 treatments, and they work in the 2 different groups that you're breaking down based on genotype. So in treatment A, the blue guys do really well and the green guys don't, and the exact opposite in treatment B, where the blue guys fail but the green guys do really well. So you can give the treatment based just on this one polymorphism that differs between the 2 groups. And what that leads to is how we would use this in the clinic, which is prospective genotyping. So people would come in to the clinic and we would take a blood sample or a cheek swab, genotype them for RS678, 849, and then based on the genotype, if they were CC, we'd give them methadone. If they were CT or TT, we'd give them buprenorphine. And then hopefully that would improve the overall treatment efficacy for the group as a whole. But specifically for these, specifically for these 2 groups that are given the wrong medication, so the medication that's not working as effectively for them. So overall, you're seeing about 50% opioid positive tests in the entire population, but that's really 2 groups for both of these, one that's around 30 and one that's around 70%. So while there will be an improvement overall, hopefully, from 50% to 30%, really the benefits are in this half of the population, and you're really cutting their opioid use in half, from about 70% to about 30 to 35%. So that's hopefully, if we can replicate this, that's where the benefits would be. So to summarize real quickly, we've got a genetic variant in the delta opioid receptor, and it predicts opioid treatment outcome in African Americans. It has to be replicated, but if we can replicate it, we'd be able to select the medication based on their genotype, and that would reduce illicit opioid usage in patients, hopefully. So just to wrap up here, I'd like to thank Wade Berrettini, who is my boss and sitting over there, for letting me work on this. He's a great mentor, really good at getting all of his postdocs involved in a lot of, and meeting a lot of people in good situations. Tony Kim Clark is the postdoc who's now in Scotland, and she wrote the paper on findings in OPRD1 in European American females. Also like to thank the START clinical trial people. They've been great help with putting this manuscript out, and just really I appreciate getting the chance to work on this study. And I got training grant funding, the START Delaware Valley Node, and a couple of NIDA grants that Wade has. Thank you. Any questions?
How much does this genetic test cost per test?
Per test? Not a lot. It's sort of an economy of scale thing. Wade, you actually might know how much a TACMAN assay costs per. There you go. It's very little. You do have to have a machine to do it though. So the machine is the intro cost. Realistically, if you were going to do this in the clinic, I don't think you would either send it away to a place that had it, or you could probably just run a PCR. You could probably set it up to do a PCR that way. We haven't attempted it, but it would be relatively cheap, I think.
Sorry, can I ask a question?
Okay.
It's fascinating. Can I ask, though, with a bit of note of caution, how many of these kinds of studies actually get replicated?
I don't know because those non-replications aren't published.
Okay.
I honestly don't know.
Okay. Well, I just remember that used to have the same talk given about schizophrenia, and you could say if you had a certain genotype of COMT, and you could give that to an adolescent, and you say, right, if you've got this genotype, then you can go and smoke cannabis, and you won't get schizophrenia. If you don't, if you have this genotype, then don't smoke cannabis. But that has never been replicated.
Yeah, no, that is a very good point, and that's why I had that big caveat in bold, which is that it needs to be replicated. Don't like go use this in your clinics or anything until it's been replicated, because basically in genetics we've had just tons and tons of false positives that have never been replicated again. And while this is very promising and very interesting, and we're hoping it's going to work out, until it's been replicated, don't take it as gospel. Okay, so this is our break time. It's 10 a.m. now, so we're going to take a 10-minute break and reconvene at 10:10 for the second half. Thank you all for being here.